Welcome everyone to this last session. Indeed, we are arrived at the last session of this comprehensive webinar program on thrombotic microangiopathies. So I think you already know the house rules, but I will briefly repeat them. So this session is recorded, as you are seeing, because it will implement our e-learning platform, so the ERN-EuroBloodNet platform, because indeed this program is organized by the European Reference Center on Rare Hematological Disease and also the CNR-MAT, so the French National Center for the Thrombotic Microangiopathies. As you know, you have the possibility to address questions, if any, at the end of the presentation. And you can both write them in the chat, or if you feel at your ease, you also can unmute you and directly ask your questions. And finally, as you know, this program is accredited by 11 continual medical points issued by the European Board of Accreditation in Hematology. So if you have followed the whole program, you will receive the accreditation. So also for this last session, pay attention to answer the survey you are going to receive at the end of the session, because this is a way for tracking for us your presence here at the program. So the technical information are finished. I think we can welcome the today's speakers. He's the Dr. Steven Grangé, who joined recently the nephrology department of Rouen University Hospital in France. And he's specialized, of course, in thrombotic microangiopathies with a particular focus on drug-induced thrombotic microangiopathy and on intensive care medicine. And indeed, today's session is about drug-associated thrombotic microangiopathy. So please, Dr. Grangé, the floor is to you. Thank you very much.
Thank you, Mariangela. I would like to thank Paul Copo for this program and EuroBloodNet too. I understood that some of you have already participated in the previous session, so you know a lot about thrombotic microangiopathies. It's a pleasure to be with you today. I'm going to speak for the last session about drug-induced thrombotic microangiopathies. But before approaching this topic, it seems important to me. Here you have my slide with disclosures. It seems important to me to recall here what is a thrombotic microangiopathy. Thrombotic microangiopathy, as you know now, is a hematologic syndrome which always begins with an endothelial injury and activation of the coagulation cascade. The consequences are microvascular thrombosis, and you will see in these patients microangiopathic hemolytic anemia with schistocytes and peripheral thrombocytopenia. The consequence is ischemic organs and organ failures of variable severity, and you know that the organs which are the most affected by thrombotic microangiopathies are the kidneys, the brain, and the heart. First of all, let's speak about the etiologies and the outcomes of thrombotic microangiopathies with this study from my colleagues in Tours in France. Guillaume Bayer published this work in Clinical JSON in 2019. You can see that he managed to include 564 consecutive patients just in the town of Tours. And an important information is that primary TMAs represent only 6% of the patients. And during these webinars, during the Congress, we hear a lot about primary TMAs, I mean TTP, atypical HUS, but as you can see, secondary TMAs represent 94% of all TMAs, and drug-induced thrombotic microangiopathies represent here 26% of all TMAs. That's why we have to speak about this topic today. Drugs which were represented in this work were calcineurin inhibitors for most of the patients, gemcitabine, and anti-VEGF. We have two more studies from the United States to talk about epidemiology for drug-induced thrombotic microangiopathies. The first work is this one from Jacob in 2012. He reported drug-induced thrombotic microangiopathies reported to the FDA between 1998 and 2011. And you can see that the drugs which are responsible for TMAs are antiplatelet agents with ticlopidine and clopidogrel, anti-calcineurin inhibitors with tacrolimus and cyclosporine, and chemotherapies with gemcitabine, and we'll see later also mitomycin C. For ticlopidine, the mechanism is interesting because ticlopidine causes TTP-like syndrome with low ADAMTS13 activity because of ADAMTS13 antibodies. So plasmapheresis was effective in these patients, and there was no relapse after cessation of this treatment. For clopidogrel-induced thrombotic microangiopathies, they are very rare. I have never seen a clopidogrel-induced thrombotic microangiopathy. The mechanism is not well known for this class of drug. We know that thrombotic microangiopathy occurs less than 2 weeks after the initiation of clopidogrel. The second study I wanted to share with you is the study from the team of James and George, who is responsible for the Oklahoma registry, so in the United States. His team reported all the drug-induced thrombotic microangiopathies reported in this registry, and they classified the drugs in function of the causal association with the TMA. So you can see that for quinine, for example, there was a definite association between quinine and thrombotic microangiopathy. Authors could ascertain this information because there were drug-dependent antibodies for patients with quinine-induced TMA. Other drugs which are responsible for TMA here, you see that they are the same than on the previous slide. We can see that there is mitomycin, gemcitabine. We find again calcineurin inhibitors with the cyclosporine and tacrolimus. So now we'll make a focus first on the quinine-induced thrombotic microangiopathies. So Page in AJKD in 2017 reported the 19 patients with quinine-induced thrombotic microangiopathies in the Oklahoma registry. So as I told before, 18 patients had quinine-dependent antibodies reactive with platelets, but also with neutrophils. And that's why if you look at the biology of these patients, you can have neutropenia, but also DIC or liver function abnormalities. I don't know why, but there were 18 women who were affected by quinine thrombotic microangiopathy out of the 19 patients. Quinine exposure was in pill form for 18 patients and as tonic water for 1 patient. And one characteristic of these clinical thrombotic microangiopathies is the severity of the renal failure, with 17 of the 18 surviving patients who required dialysis and 14 patients who developed CKD. Now we will speak about chemotherapies-induced thrombotic microangiopathies because they are frequent. The first important point when you have a patient with a cancer and with chemotherapy is to distinguish cancer-induced thrombotic microangiopathy and chemotherapy-induced thrombotic microangiopathy, because the management is not at all the same. Unfortunately, patients with cancer thrombotic microangiopathies have a characteristic presentation with a major deterioration in their general status, with often weight loss and bone pain. They have specific biological abnormalities with the absence of renal insufficiency in most of the patients. They have circulating erythroblast. It means an erythromegalemia because of bone marrow infiltration. Indeed, patients who have a cancer-induced thrombotic microangiopathy often have metastatic adenocarcinoma. And if we perform a bone marrow exploration in these patients, for example, in this case series, you can see that most of the patients, excuse me, it is this slide. You can see that most of the patients in this case series have bone marrow metastasis on the bone marrow exploration. And if you perform a myelogram in patients with cancer and thrombotic microangiopathy, if you see bone marrow metastasis on the myelogram, you can be sure that the TMA is due to the cancer and not to the chemotherapy. So let's say a word about chemotherapies-induced thrombotic microangiopathies. The first one is the mitomycin C. Mitomycin C associated TMAs. There is not much literature about mitomycin C associated TMAs. It is an old literature. You can see in this old studies that the TMA occur in 2 to 15% of patients receiving mitomycin C. Clinical features typically occur 4 to 8 weeks after the last mitomycin C infusion. And as it is the case with gemcitabine, you need an important cumulative dose to be sure that the TMA is due to the chemotherapy and not to the cancer. A clinical characteristic is the lung involvement in these patients with dyspnea, lung edema, and sometimes an acute respiratory distress syndrome, leading the patients, unfortunately, in the intensive care unit. These patients have a hemolytic uremic syndrome with an acute kidney injury in most of the patients. The ADAM TS13 is normal or mildly decreased. And unfortunately, these patients have a poor prognosis with death 4 months after the diagnosis. Now we will speak about gemcitabine-induced TMAs. We are lucky to have 2 recent studies about gemcitabine-induced TMAs. The first one is this retrospective study from Florence Davier in Marseille, in France. She managed to include 120 patients from 3 registries in France. What we learned is that the TMA occurred 210 days after the initiation of the treatment with gemcitabine, and the cumulative dose was important with 13 grams per square meter. You can see that most of the patients had edema and an exacerbated hypertension or a new onset hypertension. Excuse me. Concerning the type of the treatment, all the patients, of course, had a cessation of gemcitabine, and I was surprised when I read this study that 40% of the patients had plasmapheresis. I should say to you that in our hospital, we do not perform plasmapheresis for patients with chemotherapies induced thrombotic microangiopathies, because there is no evidence-based medicine for that, I think. Concerning the response to treatment, we can retain that 1/3 of patients had a complete remission. It means hematological and renal remission. 1/3 of patients had hematological remission only, and 1/3 of patients had no remission. Concerning the role of plasmapheresis in these patients, you can see here the Kaplan-Meier survival estimates. You have the patients treated with plasmapheresis, it is a red line. Patients without plasmapheresis, it is a blue line, and you can see that patients who had plasmapheresis had a poorer prognosis. But it is very difficult to interpret, because patients who had plasmapheresis were the more severe patients with a higher creatinine here, and more patients who needed renal replacement therapy. The second study I wanted to share with you about gemcitabine-induced thrombotic microangiopathies is a study I have done with Maximilien Grall in Rouen University Hospital too. We wanted to evaluate the efficacy of eculizumab in gemcitabine-induced thrombotic microangiopathies with the help of the French Thrombotic Microangiopathies Reference Center and Paul Copo. So we describe the clinical characteristics of patients and outcome of patients presenting gemcitabine-induced TMA treated by eculizumab, and we excluded the patients with cancer-induced TMA. We could include 12 patients in this study. 100 of the patients had AKI, with 58% of the patients who had a stage 3 KDIGO AKI, and 17% of the patients who needed renal replacement therapy. You can see that the median time from gemcitabine initiation to occurrence of the TMA was 6 months, and that the cumulative dose of gemcitabine was 27 grams. Eculizumab was started after a median of 15 days, and I have to say that it is a limit of the study, because we know that eculizumab is effective when it is prescribed early in the course of the disease, and 15 days I think is too late, but you will see that we have good results anyway. The median number of injections of eculizumab was 4, and 5 patients had previously plasma exchange with no or incomplete efficacy. Concerning the hematological response, you can see that here you have the number of packed red blood cells transfused to the patients before eculizumab here, and after eculizumab on the right of the slide, and you can see that after the initiation of eculizumab, we do not need to transfuse the patients anymore. So we already do think that eculizumab is effective in gemcitabine-induced thrombotic microangiopathies. If we just look at the hematological response, what about the renal response? You can see that we had 2 complete response with patients who had the same creatinine that at the beginning of the disease, and 8 patients who had a partial response. If we compare these patients treated with eculizumab to a control group of patients with gemcitabine-induced thrombotic microangiopathies but not treated with eculizumab, you can see that the estimated GFR at the end of the follow-up was 45 ml per minute in the eculizumab group, compared to 33 ml per minute in the control group. So maybe there is a better renal response in patients treated with eculizumab. We also wanted to try to understand why eculizumab could be effective in these patients. For that, we looked at the expression of C5b9 in the glomerular and tubular membrane on the kidney biopsy of these patients. We had 3 patients who had a kidney biopsy in our patients, and we compared these biopsies with control group with for patients who had minimal change disease. We know that patients with minimal change disease do not have deposits of C5b9. And what we found is another expression of C5b9 in the glomerular and tubular membrane and in capillary wall in patients with gemcitabine-induced TMAs. It suggests that maybe there is another activation of the complement alternative pathway in patients with gemcitabine-induced TMAs. So the question is, are secondary TMAs related to complement dysregulation? To answer this question, we have this study from Alice Leclerc in Nantes, in France. She performed this retrospective study in which she included 110 patients with secondary TMAs, including 29% of the patients who had drug-induced TMAs. And in this cohort of patients, they searched for variants for the complement alternative pathway, and they only found 6 patients with rare variants and only 2 patients with pathogenic variants. There was no difference if we compare this proportion of patients with variants, if we compare these patients with healthy individuals. So we can say that atypical HUS that you heard about in previous webinars and secondary TMAs, it's not the same disease. They are not the same disease. Maybe there is a transient complement activation in gemcitabine-induced TMAs and in other secondary TMAs, but it is not mediated by genetics. A systematic screening for complement gene variants should not be warranted in patients with secondary TMAs. What I can say to you about interest of C5 blockade in patients with secondary TMAs, I think that we cannot answer this question currently. We need to have more studies to answer this question. Next, I would like to speak to you about anti-VEGF thrombotic microangiopathies. We are lucky to have this study from my colleague Hassan Izzedine in Paris, in France. It is a single center study, and even if it is a single center study, he managed to include 100 patients with biopsy-proven kidney diseases associated with anti-VEGF. It's impressive, and what he found are thrombotic microangiopathies in 73 patients treated with monoclonal antibodies against VEGF, including 61 patients treated with bevacizumab. Patients who were treated with tyrosine kinase inhibitors did not have TMA, but they had on the biopsy minimal change disease or segmental glomerulosclerosis, focal and segmental glomerulosclerosis. The clinical and biological characteristics of these patients are here. You can see that most of these patients had hypertension and macroproteinuria, an important proteinuria between 2 and 3 grams per day, but the creatinine is normal or subnormal in these patients. We do not have severe acute kidney injury in these patients. How does it work? On the left on the slide here, you can see the normal crosstalk between endothelial cells and podocytes. When everything is normal, the podocyte here synthesizes the VEGF, and the VEGF is going to bind its receptor VEGF VEGFR2 on the endothelial cells, and endothelial cells can stay healthy. But if you have patients treated with anti-VEGF antibodies, you can see that the antibody is going to bind the VEGF, and VEGF cannot bind its receptor on endothelial cells, and podocytes and endothelial cells then will suffer. Maybe we have another mechanism to explain anti-VEGF thrombotic microangiopathies. Here you have the podocytes in green, and you can see that this podocyte synthesizes VEGF. The VEGF will have an autocrine effect, but it will have also a paracrine effect. And the consequence is the production of complement factor H by the glomerular endothelial cells. But if you do not have VEGF because patients is treated with anti-VEGF, you will not have complement factor H anymore. And you must remember that factor H usually regulates the complement alternative pathway, and if you do not have factor H anymore, there is another activation of the complement alternative pathway with endothelial damage. For the last drug I wanted to tell you about are proteasome inhibitors associated TMAs. We have this beautiful work from Jennifer Wee, who works at the Mayo Clinic, and she made a study in which she could include 11 patients with either bortezomib-induced thrombotic microangiopathies or carfilzomib-induced thrombotic microangiopathies. She included patients from USA, Belgium, and Greece. What we learn about the proteasome inhibitors associated TMAs, thanks to the study, is that there is a normal ADAM-TS13 in the 5 patients when it was dosed. All patients had a normal C3, and the genetic studies regarding the complement alternative pathway was normal in the 2 patients when it was done. The mechanism is not well understood, because you can see that half of the cases occurred within 14 days of drug initiation, but the other half occurred later in the treatment. You can see here that TMA occurred sometimes several months after initiation of the treatment. You can see that there is a severe acute kidney injury with half of the patients who needed dialysis. The mechanism is not well known, as I said before, but authors suggest that NF-kappa B inhibition induced by proteasome inhibitors can lead to VEGF pathway inhibition, and finally microvascular injury to the glomerular capillaries, and proteinuria, and acute kidney injury. In these proteasome inhibitors, thrombotic microangiopathies, maybe there is a role for the complement alternative pathway too, because we have a beautiful work from Mikel Blasco in Barcelona, who performed this study in which he included 4 patients with myeloma or plasmacytoma, and who are treated with carfilzomib. You can see that there is a severe renal failure here too, because 3 out of the 4 patients needed dialysis in this study. But the study is beautiful because the author tried to understand why these patients had TMA, and for that authors obtained plasma sample from the patients during the acute phase of the disease, and they brought this plasma sample they brought in contact with the endothelial cells in culture, and what they found are C5 benign deposits on these endothelial cells. It suggests that there is a complement overactivation in these patients. So 3 out of the 4 patients had these deposits of C5b9. And if we make focus on the first patient here, you can see that he had deposits of C5b9. Then he was treated here with eculizumab, and you can see that the C5b9 deposits decreased after initiation of the treatment. Here it is 1 week later, and here 2 weeks later after initiation of the treatment. So maybe there is an overactivation of the complement alternative pathway in proteasome inhibitors, TMAs. Well, what about the treatment now? It's very complicated to answer because we do not have specific therapies currently. So what is very important in my point of view is as the screening of these patients, we have to monitor hypertension. We have to, these patients should have a monitoring of proteinuria with urine dipstick test. And if you find patients with an exacerbated hypertension or a new onset hypertension, you have to treat it with ACEIs or ARBs. Concerning the specific treatment, patients with chemotherapies, but you have to stop chemotherapy. In my point of view, plasmapheresis, steroids, rituximab, or other immunotherapies do not work in drug-induced thrombotic microangiopathies. Concerning the complement C5 inhibition, maybe in the future, we would say that there is a place for C5 blockade, maybe in gemcitabine-induced thrombotic microangiopathies, maybe in proteasome inhibitors thrombotic microangiopathies. In conclusion, what you should get home for, what are the messages that you should keep in mind. Cancer-associated TMAs and chemo-associated TMAs need to be distinguished on the basis of clinical evaluation, and maybe with the help of the myelogram, it can be useful because patients who have a cancer thrombotic microangiopathy have a terrible prognosis, poor prognosis, and they should not be treated with plasmapheresis or expensive drugs. We see that drug-induced TMAs have several mechanisms, sometimes with an endothelial toxicity, with an important community dose. It is the case for gemcitabine and mitomycin C. Kinin-induced thrombotic microangiopathies are immune-mediated. We saw that there was a normal ADAM-TS13 except for tiplopidine-induced thrombotic microangiopathies, and maybe there is a transient overactivation of complement alternative pathway in patients with gemcitabine or proteasome inhibitors thrombotic microangiopathies, induced thrombotic microangiopathies. I think that it is really important to make an early diagnosis in these patients, and for that we have to monitor the blood pressure and the proteinuria by performing urine dipstick tests. Unfortunately, we do not have currently guidelines on the treatment, and the treatment will depend on the intermediate drug class. That's why it is very important, I think, to obtain an opinion and advice from regional reference centers when you have patients with a drug-induced TMA, with drug-induced TMAs. The last thing I wanted to tell you is that the data presented here today is biased because you know that there are publication bias. I mean that when you treat a patient with eculizumab or rituximab and the evolution is favorable, it is published. But if the evolution is not favorable, it is not published. So it's very complicated to interpret the literature about drug-induced thrombotic microangiopathies. To better characterize these drug-induced thrombotic microangiopathies, we created the last year a new registry, which is just done for drug-induced thrombotic microangiopathies. So that's what I wanted to tell you about drug-induced thrombotic microangiopathies today. So I am available for questions if you have. But thank you for your attention.
Thank you very much for your comprehensive presentation and also very clear presentation. So as said before to the audience, you can both unmute yourself or write questions in the chat. And this is indeed the last chance for asking questions on thrombotic microangiopathy. So if I were you, I won't lose these possibilities. So maybe we wait for some minutes to see if some questions drop by. So we have some questions in the chat. The first one said, thank you for your presentation, very complete and rich of details. I might be wrong, but I haven't heard mention the TMA-induced association between emicizumab, bispecific AB mimicking coagulation FE3, and FIBA, FIBA.
Okay, thank you for this question. You're right. I did not mention these TMAs induced by emicizumab and FIBA, but there are a few case reports currently in the literature, and the mechanism is not well understood. I wanted to share with you the drug-induced thrombotic microangiopathies, where we have a little evidence-based medicine to share my experience with you, but I'm not able to tell you more about emicizumab and FIBA thrombotic microangiopathies. Was extravascular hemolysis identified in drug-associated TMAs? So what do you mean by extravascular hemolysis? It means medullary hemolysis. I'm not sure to answer to understand the question here.
Oh, I can be more precise. Can you hear me?
Oh, yes, I can hear you.
Oh, so thank you for the presentation first. Extravascular hemolysis has been described in congenital TMA. And I was just wondering, and it was one of the main reasons for requirement for red blood cell transfusion. And you mentioned that following eculizumab, there was no more any requirement in need for red blood cell transfusion. And I was wondering whether this was due to intravascular hemolysis or intravascular or extravascular hemolysis. Because C5 inhibitor usually doesn't work very well for the extravascular component of the hemolytic process.
But in patients with gemcitabine-induced thrombotic microangiopathies, what I am sure is that these patients have intravascular hemolysis because we can see it on biological data. They have schistocytes, they have higher LDH levels, they have a low haptoglobin. So there is an important intravascular hemolysis, and I am not I did not see any study with the proof that there was an extravascular hemolysis in these patients in gemcitabine-induced thrombotic microangiopathies or in other drugs in other drug-induced thrombotic microangiopathies. I am not aware of that.
Okay, thank you. As I can also maybe try to contribute to the previous question. Okay. FIBA, which is a bypassing agent used for the hemophilia A people who have developed inhibitors against factor VIII, a few cases, as you mentioned, between the use of emicizumab and fiber have been described in the phase 3 study that was published in the New England Journal of Medicine 2 or 3 years ago. But so far, the connection, the mechanism of action or pathophysiology have not been elucidated, as you said.
Okay, thank you.
Thanks to both.
And Professor Grangé, thank you for your answer, and thank you, Dr. Grangé, for the presentation. What is your personal opinion on the possible mechanism of action? Just a speculation, of course, in the context of a discussion.
I spent some time thinking about that, Mario, and honestly, I don't know what the real mechanism is. It's really a very rare event that has been almost never described before the use of emicizumab, and was apparently only linked to Faber administration in people with hemophilia A. We really don't know what the mechanism is. It might be elucidated in a few months or in a few years, but so far we really don't know. It seems to be very different from all the other mechanisms that were nicely presented today.
Thank you. Thank you so much.
Welcome. You're welcome.
So I think there are no more questions. So, well, it has been a pleasure for having hosted this 15 session dedicated to thrombotic microangiopathies. So you will find the record of all those presentations in our website, e-learning platform, and YouTube channel, educational YouTube channel. So if you want to receive some sessions, they will be there. So thank you to everyone to be here. Thank you to Dr. Grangé for having accepted our invitation. And see you maybe next year. Thank you very much.
Thank you.
Thank you very much.
Bye-bye.
Bye.